Welcome back to the Deep Dive. Today, we are tackling a stack of research on one of the most pressing and, frankly, terrifying clinical syndromes in cardiology, acute decompensated heart failure, or ADHF. This is the condition that sends patients rushing to the hospital, usually feeling like they're suffocating from fluid overload.
And it presents so differently in almost every single person, which is what makes figuring out the right treatment path so incredibly challenging.
Right. And the stakes are just incredibly high.
They really are. An ADHF admission isn't just a stressful event, it's a huge marker for future poor health. The outcomes, when you look at the data, are alarming.
Alarming is the right word. We're talking about nearly half of these patients being readmitted within just 6 months.
6 months. It's a revolving door for so many people.
That number alone, it just underscores how hard it is to manage the crisis. And then, crucially, that transition back home. And the mortality figures are stark.
Yeah, they are. It starts with about 5% mortality just during that initial hospitalization.
But then it jumps to, 20% cardiovascular mortality within a single year?
Exactly. And if you connect this to the bigger picture, the combined incidence of major adverse cardiovascular events, so death, rehospitalization, heart attack, stroke, sudden death, that reaches 50% at 12 months.
50%. So you have a 1 in 2 chance of a major event within a year.
That's the reality.
So that puts our mission today into sharp focus. We know ADHS management is difficult, focused on volume control, hemodynamic optimization. So we need to unpack the core principles, figure out what flags a patient for the worst outcomes, and most importantly, look at the trials that tell us what actually works.
And what doesn't, because there's a long list of things that seemed logical but just failed.
Okay, so let's unhack this. Where do we start?
You have to start where all acute management begins. Identifying the factors that triggered the decompensation in the first place. You can't fix the failure until you stop what's causing it.
And for you, the listener, it's so important to realize that the root cause isn't always some dramatic new cardiac event.
Right. Often it's everyday things like not sticking to a strict medication plan or even just a little bit of dietary salt and discretion. A salty meal can be enough.
Those are the behavioral factors, but we also have to look at medications, right? Things that can just unexpectedly worsen heart failure.
Yes. This is where patients get into trouble completely inadvertently. We're talking about a wide range of meds, including common over-the-counter stuff.
Like NSAIDs?
Exactly. Non-steroidal anti-inflammatory drugs. They cause fluid retention.
It's amazing that something like an ibuprofen for a backache can land a heart failure patient right back in the ICU. What else is on that list?
Well, it's surprisingly diverse. You've got thiazolidinidones, which are for diabetes, some cancer therapies, TNF inhibitors for autoimmune conditions, and even, specific cold and flu preparations that have cardiac stimulants in them. You have to ask about everything.
Once those everyday triggers are ruled out, the focus shifts to more systemic causes. What are the big medical issues you have to hunt for?
It's mandatory. You have to systematically search for acute coronary ischemia. That's a huge trigger.
Okay.
Then you look for arrhythmias, atrial or ventricular, problems with heart valves, any kind of systemic infection sepsis puts huge stress on the heart, and critically, a pulmonary thromboembolism, a blood clot in the lungs.
So identifying the trigger is stage 1. But with those mortality figures, you need to know immediately who's on the steepest decline. How do you stratify that risk?
So registry analyses have been vital here. They've identified very specific, measurable things that correlate strongly with worse outcomes.
Like what?
We look at 3 main numbers: a blood urea nitrogen, or BUN, level over 43, a systolic blood pressure below 115, or a serum creatinine level above 2.75.
Those are incredibly specific cutoffs. Why do those numbers, especially the kidney function ones like a BUN over 43, just scream high risk?
Because they tell you more than just that the kidneys are impaired. A high BUN, especially when it's high relative to the creatinine, it often suggests, massive neurohormonal activation and reduced effective circulating volume.
Even if the patient is full of fluid.
Exactly. It's a sign the body's compensatory mechanisms are failing. You see those numbers, plus high cardiac biomarkers like natriuretic peptides and troponins, you have to be aggressive. Immediately.
And speaking of aggressive intervention, what about pulmonary artery catheters? Is that standard practice for these really sick patients?
It used to be, but the data is clear now. Routine use of a PA cath is not recommended.
So it's not for everyone?
No. It just adds risk without improving outcomes for most people. It's really restricted now to the most complex cases, cardiogenic shock, patients who don't respond to diuretics, that kind of thing. It's a diagnostic tool, not a routine monitor.
That's a great clinical distinction. Okay, let's pivot to the absolute cornerstone of acute management, volume control.
This is where the patient gets that immediate, tangible relief. 4 V-loop diuretics are essential, things like furosemide. They work fast, they relieve that congestion.
And it has to be IV because...
Because in that acute state, the gut is often swollen and congested, so oral drug absorption is totally unreliable.
But the sources describe this as more of an art, not a science. Why the ambiguity?
Ambiguity is all in the dosing and the delivery. Clinicians are always debating, do I give a high dose or a low dose, a big push, a bolus injection, or a continuous IV drip?
And the trials haven't settled it?
Not really. A continuous infusion might be smoother, maybe less toxic to the kidneys, but you risk the body getting used to it. A big bolus works fast, but can cause, pretty significant adverse events.
So you have to tailor it to the patient in front of you. What happens when they're refractory? When the diuretics just aren't working?
That's when we escalate to what's called sequential nephron blockade. Basically adding a second type of diuretic, a thiazide like metalazone, on top of the loop diuretic.
How did that actually work? How does it overcome the resistance?
So loop diuretics work in one part of the kidney's filtering system. Over time, other parts downstream start to compensate. They start reabsorbing more sodium. By adding the thiazide, you block that compensatory mechanism. It's like blocking 2 different escape routes for the sodium and water.
But I remember reading there's a big warning that comes with that combo.
Oh, yes. It's very effective, but it significantly increases the risk of severe hypokalemia, dangerously low potassium. It's an effective maneuver, but it's risky. You have to watch those electrolytes like a hawk.
So we've got the fluid moving.
Yeah.
What's the end goal? What defines success?
The primary goal is achieving euvolemia, a balanced fluid state. We know that any residual congestion is the strongest predictor of another decompensation.
And success is confirmed by what?
By the clinical picture. The patient feels better, they're not breathless, the jugular venous pressure in the neck goes down, you don't hear crackles in the lungs, the swelling resolves.
I always thought it was just about tracking their weight loss.
People use weight, but here's an interesting nugget. It can be surprisingly hard to interpret. It doesn't always correlate that well with the outcome. What's far more useful is getting a pre-discharge natriuretic peptide level.
Why that?
If those levels haven't dropped enough, it's a huge red flag for residual risk, even if the patient feels and looks better.
Let's talk about one of the most frustrating parts of this. The cardiorenal syndrome, or CRS.
Ah, yes, CRS. The vicious cycle between the heart and the kidneys where trying to fix one seems to hurt the other.
And what's the mechanism? I think the old thinking was just that the heart wasn't pumping enough blood to the kidneys.
Right, that the kidney was just starving for blood flow. But what's fascinating is that a lot of CRS patients actually have a preserved cardiac output.
So it's not a pump problem.
Not always. The prevailing hypothesis now is what we call backward failure. All that fluid retention increases pressure inside the abdomen, which then compresses the veins coming out of the kidney.
So the kidney can't drain properly. It's a plumbing issue.
It's a pressure and drainage problem more than a flow problem.
That paradigm shift brings us right to an intervention that was designed to bypass all this complexity. Ultrafiltration.
Right, also known as aquapheresis. It sounds so straightforward, right? Just filter the excess water directly out of the blood.
Exactly. Why did this invasive approach turn out to be such a disappointment?
Well, the theory was great. You remove fluid, but you preserve electrolytes better than with diuretics. The crucial insight, though, came from the CARESS-HF trial.
What did they do in that trial?
They compared ultrafiltration directly against a good, stepped-up diuretic strategy in patients with ADHF and worsening kidney function.
And the result?
Well, both groups got rid of about the same amount of fluid, around 5.5 kilos. But the ultrafiltration group saw a statistically significant rise in their serum creatinine. Their kidney function actually got worse.
Wait, how is that possible if they're removing the fluid that's causing the congestion?
The hypothesis is that by pulling fluid so rapidly from the bloodstream, it caused this acute plasma volume contraction. It basically temporarily dehydrated the circulation, which dropped the perfusion pressure to the kidney and caused an acute injury.
So faster isn't better?
Not at all. The conclusion was pretty unambiguous. Ultrafiltration is argued against as a primary strategy here.
That really undermines that idea. Okay, moving to other drugs, the vasodilators. We have the standards, like nitroglycerin and nitroprusside.
Correct. Nitroglycerin mainly works on the veins, reducing the preload, the volume returning to the heart. Nitroprusside is much more potent, works on arteries and veins, but you have to watch for a sudden drop in blood pressure.
And then we get into the failed attempts to use these new recombinant peptides, starting with nasiritide.
Nasiritide. The synthetic BNP, its use really fell off because of some early safety concerns. But then the massive ASCEND-HF trial over 7,000 patients came out.
And what did it find?
It didn't confirm the mortality risk, which was good, but it found no clear clinical benefit at all. No improvement in mortality, no reduction in readmissions, not even significant improvement in shortness of breath.
But more hypotension.
But more hypotension. So routine use is just not recommended.
And that theme of failure continued when they tested the so-called acute injury hypothesis.
Yes. This was the idea that if you could aggressively vasodilate the heart right away, you could protect it from the long-term damage caused by being stretched out during the acute episode.
So the true AHF trial tested this with a drug called ularitide.
They did, and they intervened incredibly fast, less than 6 hours after the patient showed up, with a dose that did, in fact, reduce the ventricular wall stress. It worked hemodynamically.
What?
But there is absolutely no improvement in clinical outcomes. None. No change in mortality at 6 months.
That's a profound failure. It doesn't just say the drug didn't work, it says the whole theory might be wrong.
It absolutely shattered that hypothesis. It suggests that the acute stretching isn't the main driver of the bad long-term outcomes.
And the risk profile just keeps getting worse when we move to agents designed to boost the heart's contractility, the inotropes.
Right. Agents like dopamine, dobutamine, and milrinone. They do what they're supposed to do. They improve contractility, they boost cardiac output. Seems like a logical fix for a weak heart.
But the danger is huge.
Immense. Long-term inotropic therapy is strongly associated with a higher risk of mortality. We think it's because they increase the heart's oxygen demand and can trigger lethal arrhythmias.
And which trial really cemented that routine use is too dangerous?
That would be the OppiTime CHF trial. It looked at routine, short-term use of milrinone. The results were crystal clear. More atrial arrhythmias, more prolonged hypotension, and zero benefit in mortality or hospitalization.
So strongly discouraged. If they're that dangerous, when are they used?
Really only in 2 scenarios. One, as a short-term bridge to a heart transplant or an LVAD in someone with profound cardiogenic shock.
Okay.
And 2, sometimes as selective palliative support in true end-stage heart failure. Outside of those extreme situations, the risk just far outweighs the reward.
It's remarkable. So many logical interventions have failed. And it wasn't just vasodilators and inotropes, right?
Not at all. We had agents targeting the kidneys differently, like adenosine receptor antagonists in the PROTECT trial. No benefit.
And tolvaptan.
The vasopressin 2 receptor antagonist, tested in the huge Everest trial to help excrete free water. Again, no benefit on mortality or morbidity. Across the board, novel acute interventions just kept failing.
So if all these high-tech acute interventions aren't moving the needle on the long-term prognosis, then the crucial period must be that transition.
Absolutely. The focus has to shift the moment the patient is stable. Management becomes goal-directed, relieve symptoms, suppress the triggers, and then focus intensely on that transition home.
Which involves things like patient education on diet, symptoms.
All of that. And early post-discharge follow-up. It's statistically proven to reduce readmissions.
And for patients with HFrEF, heart failure with reduced ejection fraction, the key seems to be getting them on guideline-directed medical therapy, or GDMT, quickly.
It's paramount. We used to wait, defer it until they saw their cardiologist weeks later. The data now show that starting GDMT before they even leave the hospital is linked to better adherence and much better outcomes.
Which brings us to the game-changing data from the Pioneer HF trial.
Exactly. That study fundamentally shifted the timeline.
What did it show about initiating sacubitril valsartan?
Pioneer HF compared starting sacubitril valsartan, a cornerstone of modern HFrEF therapy before discharge, versus the old way of starting a standard ACE inhibitor.
And the result was a huge success.
A resounding success. In stabilized patients, starting at pre-discharge led to much greater reductions in natriuretic peptides and, critically, lower rates of death and heart failure readmission at 8 weeks.
So the proven path isn't some complex, invasive acute maneuver.
No.
It's diligent volume control, finding the trigger, and then successfully bridging the patient to effective long-term therapy before they even walk out the door.